The following podcast is part of a certified educational activity titled Remembering Brain Health, Reshaping Care Models to Achieve Meaningful Impact Across the Lifespan. Access the entire activity and complete the post-test at peerview.com/NDZ860. Downloadable slides and practice aids are also available.
Welcome to Remembering Brain Health, a PeerView live event. And for everybody that's on virtually, glad you're on with us tonight. So we're going to be talking about reshaping care models to achieve meaningful impact across the lifespan. So the panelists tonight are myself, Dr. Kilgore, and I have Amy Klinger with me, and then Scott Kaiser. Amy and I worked together with AAPA when we put together a toolkit. And in our clinics, we were doing screening for cognitive decline. All right, so I'm going to start. Again, I'm Dr. Kilgore. I'm associate professor and lead of the behavioral addiction medicine at the DMSC program at the University of Lynchburg School of Medicine and Health Sciences. And I'm the medical director of the Community of Hope Health Clinic in Pelham, Alabama. So a little bit about this. Again, you can scan this code, not right now, but when you get the slides, you can scan the code. This will give you access to all of this additional material. You can see practice aids, podcasts, and educational activities. So a little bit about Alzheimer's disease. It is a growing epidemic. Dementia is one of the biggest global health crises of the 21st century. Alzheimer's disease is thought to account to about 60 to 80% of the global dementia cases. 6 to 9 million Americans are living with Alzheimer's disease, and that number is projected to grow to about 13.8 million by 2060. The healthcare system faces a shortage of dementia care specialists, an unprepared infrastructure, and also a growing aging population. The current status of our screening and diagnosis is too little, too late. So a little bit about the AD continuum and the pathological process timeline. You have to start screening early. Something Amy and I have been doing for a couple of years now is to screen our patients in our clinics to identify early symptoms. You can't really start too young. I usually, for me, cue around 50, but I do go earlier and start gathering information on my patients. So the pathological process leading to the neurodegeneration involves aggregation of amyloid and tau proteins that eventually leads to neuronal cell death. Neurodegeneration and mild cognitive impairment occur only after significant irreversible damage. So the time before mild cognitive impairment is that prevention period. And you can see here on the slide, you go from birth and then somewhere about middle age, and that's pretty broad, you can start getting those inflammatory factors, and we'll talk a lot about those tonight, that can impact you. And then you end up to a point where you have so much of the amyloid and tau proteins, they begin to aggregate. They can cause all kind of problems. You can have neuronal death. And then that will lead over a period of time to your mild cognitive impairment. And then over a certain period of time, they say on our slide here, 1 to 2 years, it varies with individuals, then you enter into that phase of dementia, and that could potentially last until death. So our goals today are to equip you with strategies for delaying cognitive decline in your patients through the promotion of healthy brain habits and modification of risk factors, improve the ability with using validated cognitive assessment tools to identify the signs of MCI and distinguish them from normal age-related changes, and then provide you with tools to engage the patients and their care partners in an educational discussion about brain health and cognitive concerns. Dr. Kaiser?
Thank you so much. Yeah, Scott Kaiser, family physician, geriatrician. I am the CEO of a startup, Determined Health, focused on addressing social determinants of health, and director of geriatric cognitive health at the Pacific Brain Health Center in Los Angeles. I've been focused on dementia care in my practice for at least a decade now. And I really appreciate all of you taking the time to participate in this tonight. We heard, 7 million Americans living with this now in an aging population. One of the greatest challenges of our time. Public health, global health, economic, social. This is a really impactful challenge. And it's all changing so quickly. Just today, the FDA approved the first blood-based biomarker, which is going to certainly change the field and make everything we're talking about tonight all the more critical. These fundamentals of early detection, brain health, really critical. So what is brain health? Okay, the WHO definition is that brain health is the state of brain functioning across cognitive, sensory, social, emotional, behavioral, and motor domains, allowing a person to realize their full potential over their life course, irrespective of the presence or absence of disorders. Changes in brain health are driven by a complex interplay of risk and protective factors. Some modifiable, others are not. And that's what we're going to be talking about. What are those modifiable risk factors? In terms of the non-modifiable risk factors, very important to be able to recognize those so you can have sort of a baseline understanding of where to categorize the baseline risk. But really key is recognizing those modifiable risk factors, which we're going to see occur throughout the life course. So let's talk about the continuum of cognitive impairment. So, right, we go along. I mean, we could go back to the womb in terms of the fetal development of our brains and talk about the growth of brain cells. And as we get older, these things can become an issue where we may have some subjective cognitive decline. We may start to notice changes. Those may be normal, maybe not. This is where we have to get into differentiating. But when people start having these self-perceived memory or cognitive decline issues, but they still don't have the objective findings, right? Cognitive functioning falls within normal limits with all of our assessments and data. Then we're talking about subjective cognitive decline. Now, this is not something to be dismissed. You don't just say, okay, well, don't worry about it, it's all subjective, because this may be associated with an increased risk of developing MCI or dementia due to Alzheimer's disease. So we need to pay attention. When any patient, family member, other provider has a concern, we want to pay attention, and we don't want to just kind of say, all right, you're fine, see you later. We're staying with patients and families throughout this journey to help them at each point along the way. So now, should these cognitive issues progress to the point where you are having not only these noticeable memory and cognitive challenges like repeating questions, word-finding difficulty, but you are actually seeing objective deficits on testing, but you're still at the point where you are able to function independently, well, that's mild cognitive impairment. Mild cognitive impairment, when I find a patient with mild cognitive impairment, it's like the red lights need to be going off, and we need to bring in the SEAL team, right? Because people with mild cognitive impairment, they've already, as we saw in the previous slide, they've had pathologic changes occurring for a long time already at that point. But there's still an opportunity for us to dramatically change what their future might look like. There's still a lot of modifiable risk, right? If somebody has mild cognitive impairment, they are at significantly increased risk of going on to develop dementia. But much of that risk is modifiable. So there are things we can do, addressable factors that could significantly change what the next decades of that person's life might look like. Very important. Now, should the cognitive decline progress further, such that it's more notable, just globally notable, right? It's worsened cognition. You have subjective, objective findings. The scores on your assessments are lower, of course. But the key differentiator is that now it's gotten to the point where you've got a functional decline, a loss of functional independence. That, by definition, where you have that cognitive impairment, often across multiple domains, and the loss of functional independence, that's dementia. And I just really want to emphasize this because people get so confused. Patients will say, well, doc, do I have dementia? Do I have Alzheimer's disease? What do I have? Well, notice we haven't talked about Alzheimer's disease yet. We're just talking about this continuum of cognitive changes and this syndrome of dementia where you have these subjective, objective cognitive changes, and loss of function. Now, of course, that may be a result of Alzheimer's disease. It's by far the most common cause, but certainly there are other diseases that may be causing cognitive impairment and dementia as well. And certainly we want to be thinking about potentially addressable factors, vitamin deficiencies, sleep apnea, things that can be addressed that may be the sole reason for the cognitive impairment, or may just be accelerating the underlying process such as Alzheimer's disease. Does that make sense, that differentiation? Great. So now let's talk about the continuum of AD. So as we saw in the previous slide, you've got this preclinical AD. This is where the pathologic changes of Alzheimer's disease, these amyloid plaques and tau tangles, are accumulating before you even have any clinical symptoms, biomarker evidence only. That would be stage 1. Stage 2, you're still in that subjective cognitive decline in that you're not having objective findings on cognitive testing, but there's normal performance on these cognitive tests, but clearly a decline from a previous level of cognitive function, and certainly no impact on functional capacity, because if there was an impact on functional capacity, where would we be? Dementia, right? So we're in this early stage before MCI, before dementia, but you still have this accumulating pathology. So it's a really controversial area because not all of those people will go on to develop dementia. So at this point, screening for preclinical AD is not currently recommended outside of clinical trials. So people will say, gosh, well, I heard the FDA just approved this new test. Should I get this blood test to see if I have Alzheimer's disease? And at this point, if they're still in this preclinical phase, then the recommendation is not to do that, and that's just for clinical trials. But that is certainly the tip of the spear of this evolving landscape. There are clinical trials occurring now where people are being given these new FDA-approved amyloid-targeting therapies in this preclinical AD phase. So stay tuned for this to evolve quite rapidly. Then certainly, as people have developed mild cognitive impairment, meaning, right, they've got subjective, objective cognitive changes, not yet causing a significant functional loss, IADLs, ADLs, and such. That's MCI by definition. And they have the amyloid plaques, tau tangles. They've got the pathology of Alzheimer's disease. So now we're in this stage 3. Stage 4 is where now the cognitive changes have progressed. There's a loss of functional capacity, so we know that is, by definition, dementia. It's still relatively mild. We're talking stage 4. The reason I point this out, and I'm emphasizing this stage 3, stage 4, this early area, is because that is the segment for whom amyloid targeting therapies are approved. So very important. Again, as I said, clinical trials testing amyloid targeting therapies in the preclinical, but if people are later, the horse is already out of the barn, it's more risk than likely benefit, and there is not an indication for the amyloid targeting therapies. Does that mean we should just do nothing and say, see you later? Absolutely not. As you'll see, there are so many things we can, should, and must be doing for folks at any stage. So let's talk about prevention. When is the time to approach dementia prevention? Well, always. It's never too early. It's never too late to be thinking about dementia prevention. This is that we need to have a life course perspective. Intervention should continue throughout the entire lifespan. And if you break it down, as we've said, these pathologic changes may be occurring in our brain for decades before we even have symptoms. So that primary prevention period is really from the womb through like age 40-ish, is really where we need to be thinking about brain health in all aspects of our life, to be thinking about true prevention, primary prevention. Then in our 40s to 60s in this potential preclinical phase is where we have an opportunity for secondary prevention. And then by the time it's gotten to where somebody actually has mild cognitive impairment, sadly, we're pretty late in the game at that point. But as I said, it's a full court press. We should be doing everything we can to be able to change the course of the illness, and that's our tertiary prevention phase. So let's talk more specifically about targeting these modifiable risk factors to protect brain health. So there it is. You've got the little stroller there, the baby carriage. I would have it all the way back into the prenatal phase, right, in the womb. In utero is when we could be thinking about what's good for the brain. And all the way through late life, all the way to our last breath, there are opportunities to impact the health of our brains. And it's pretty fascinating. Actually, the Lancet Commission, commission of experts, gets together, looks at all the literature around risk factors for dementia, modifiable risk factors, and it's estimated that something on the order of 45% of dementias globally could be prevented if all of these factors were fully addressed, which is pretty striking if you think from a global socioeconomic political perspective. The fact that by 2050 we're predicted to have 150 million people with dementia, imagine if you could cut that number in half. Pretty amazing. So a real plug for public health approach and addressing all of these things throughout primary care, right? So as you look at this list here, yes, they're broken down in terms of early life, midlife, late life. I also like to think about sort of the things that are directly within our grasp in our clinical work and some other things that are a little bit more macro, but still an opportunity for us to advocate, thinking about things like air pollution, right? So for each of these things, though, for us to be really on top of understanding these as potential risk factors, identifying them, and then modifying them when possible. So there are many validated tools we can use. I'm not going to go through all of these. As Dr. Kilgore said, you have access to the slides after, but there are many validated tools that you can use in terms of assessing for these modifiable risk factors. And again, who isn't addressing these factors in their practice in some way? I don't care what specialty, what setting. We're all in contact with these issues and need to be thinking about it now within a brain health perspective. And there are things that maybe weren't traditionally part of what we considered within our practice, like understanding the impact of loneliness and social isolation. But we need to be thinking there are codes you can, in your EHR, you could code for social isolation, right? I mean, that is something we should be asking patients about and identifying so that we can intervene. This is a significant modifiable risk factor. And when we're thinking about these modifiable risk factors, a good axiom to keep in mind is that what's good for your heart is good for your brain. So the same steps that we're emphasizing to take to reduce our risk of cardiovascular disease are also reducing our risk of dementia. And that's very helpful to frame it that way because of the multitude of efforts to address cardiovascular health, but also to destigmatize, right? To normalize this conversation about brain health across the lifespan. And this, of course, then encompasses things like management of lipids, blood pressure, glucose, weight, and then being aware of how we integrate cognitive health screening into our practices, into our clinical workflows. So I've been talking about all the value of addressing modifiable risk factors. And I want to show you some of the data so that you don't say, well, that's Scott Kaiser. He's just a zealot. He just thinks everybody should be thinking about brain health. And I don't know what, it's a religious thing. Well, no, this is what the science says we should be doing. It's very clear. So an excellent study to start. And there's so many. It was hard to select just a few studies to highlight here. So we'll do some greatest hits. So Sprint Mind really showed that intensive blood pressure control resulted in reduced risk of cognitive impairment. So it was very clear that if you kept the systolic blood pressure, if you aim for that target of less than 120 versus less than 140, that we saw a reduction in MCI and composite MCI and probable dementia. You see the statistical significance over there off to the right. So you might, if you have an eagle eye, be saying, well, it didn't have a statistically significant impact on probable dementia. Well, there were many limitations, right? They had to stop the trial early. Reducing the power to detect dementia outcomes. They had to exclude patients with some cardiometabolic comorbidities. There was a potential underestimation of MCI. So many factors, but altogether, those are sort of more components of the study design and execution. Nonetheless, very clear signal around MCI and composite MCI probable dementia. So the right thing to do, particularly when we're thinking about those different stages of prevention, is to be cognizant of the importance of that less than 120 systolic target. And then when we're trying to encourage patients to be physically fit, we know that higher cardiorespiratory fitness boosts cognition and lowers dementia risk. So I tell my patients, if you exercise, if you get yourself physically fit, look at that peak VO2, treadmill duration. And so if we get our folks physically fit, it's going to help you right now. You're going to be thinking more clearly. You're going to be better focused, sharper immediately, and it's helping you in the long term. You are actively reducing your dementia risk by doing this. And this was looking at a huge data set in the UK Biobank. We know that high cardiorespiratory fitness was associated with better cognitive function, and onset of dementia was delayed by about a year and a half amongst those with high versus low cardiorespiratory fitness. And then a lot of people will say, well, what am I going to do? You know, I have a strong family history. I did my 23andMe. I've got the genes. You know, why bother? The opposite. This is very clear that the cardiorespiratory fitness attenuated that genetic risk, right? So that's very important, that your genes are not your destiny in this case. You have the opportunity to modify your risk by being physically active and getting really fit. And then this is one of my favorites because this has just had such a huge impact in my practice and the work I do, is the finger trial out of Finland. Here, they took people they had a scoring system to show people who were at significant risk of developing dementia, but were cognitively normal. And they showed that with this 2-year intervention that was diet, exercise, cognitive training, and then the vascular risk, by the way, they didn't even, intervene to address high blood pressure or high blood sugar. They just educated the patients about being proactive about monitoring those things. And that alone, that multimodal approach was very successful. Significantly better cognitive performance in those who had the multimodal lifestyle intervention versus control across multiple domains, reducing their risk of developing dementia. So again, if we took these people aged 60 to 77 and we got them in this exercise, diet, lifestyle intervention, educated them, even better, in our primary care, in our clinics, let's do the work to make sure that we are effectively managing their vascular risk factors, we could significantly change what their life and what the whole world will look like 10, 20 years from now. And this work has actually inspired a global effort of similar multi-domain interventional studies, and we're all anxiously awaiting results of the US version and the Pointer study. And again, this is something that we're going to normalize. We're going to talk about in every aspect of our practice, whatever setting we're in. We're going to talk about it socially in our lives, and then we're going to give people simple, understandable tools that will give them actionable strategies for preserving brain health across the lifespan. And here's just one example of a steps to a healthier brain that just lays it out to just keep reminding people of all these things we can do to keep our brain healthy at any point in our lives. And when we think about optimizing brain health in later life, my perspective as a geriatrician, well, what's one of the big things I'm going to be thinking about? Medications, polypharmacy, potentially inappropriate medications, identifying those. Who's heard of Beers criteria? Raise your hand if you know the Beers criteria. Great. So we're going to identify those highly anticholinergic, potentially deleterious medications, and then we're going to have a safe, concerted deprescribing process so that we can help patients safely remove these medications that could be doing significant harm. We can remind people how important it is to get their hearing assessed, send them to audiology, encourage people to use hearing aids if they're indicated, knowing that that is a significant modifiable risk factor. And we need to address the stigma associated with that. We can't have people think that okay, well, if you have hearing loss, you're definitely going to get dementia. No, if you have hearing loss, wear hearing aids, you're going to reduce your dementia risk, period. Same with vision health and frailty prevention, really thinking about identifying frailty, using available tools to identify that early so that we can modify this risk by getting people in the types of exercise interventions, lifestyle interventions, and broad-based approaches that we know work. So, working with patients to develop a brain health plan, we want to make this as routine as managing blood pressure or glucose. Patients we know are more likely to engage when the recommendations are personalized and attainable. If you just hand somebody and say, do all this, and didn't even ask them what's at all possible, it's never going to happen, right? Most of us know what we should do. We have, it's not like we thought, there was a big study that we all missed that eating a lot of donuts and sitting down and smoking was good for us, right? We know most of us know what we should do, but what we need is help coming up with a plan, just like the way we help people quit smoking, where we figure out where they are in the process. We start thinking about what motivates them, what matters most to them, and then developing a realistic, actionable plan with actionable steps and accountability. This is exactly what we need to do with our brain health prescriptions. And in this way, we can tailor the plan to their unique risk factors, their preferences, their unique characteristics, and ensure meaningful, sustainable changes. And so with that, I'm looking forward to continuing to work with all you this evening and handing it over to Amy.
Great. Thank you so much. I work in primary care in rural Idaho. And I was just curious how many people in the audience are in primary care, surgical, or specialties. Any people actually in geriatrics? Yay, that's good. We were just talking about PAs and geriatrics. So great. And what we're going to talk about today is working across disciplines. How are we going to incorporate this into our practice? And my goal is that we can help identify this at these early stages, start talking about it before we get mild cognitive impairment, and then really addressing the alarms that we get when we find mild cognitive impairment. And you're going to see that we're not very good at finding mild cognitive impairment and identifying it. And I like to see that as a missed opportunity rather than a burden in my practice, because my patients are actually interested in it. My patients want to know about it. And so that's what's an opportunity for us. So early conversations matter. I mean, we all need to be spending time with our patients. We need to be setting aside appointments just to talk about brain health when it comes up as an issue, because cognitive decline goes unrecognized in early stages. And when it does that, we're delaying diagnosis, we're infringing upon planning, and we're reducing the support that they get and that they need as they go through that spectrum of disease. So the Alzheimer's Association, Medicare, the American Academy of Neurology all recommend that we detect early and at least at the MCI stage of illness. This is the most alarming statistic to me. Several studies have indicated that 8 to 15% of individuals with MCI receive that diagnosis. So I want to say that again because I had to read this several times. 8 to 15% of people with MCI receive that diagnosis. Imagine if we did that with blood pressure or diabetes. I mean, we would be failing. And this is a huge part of our population, and it's a really important point where we can intervene. 99% of us underdiagnose it. And sometimes it is that idea that we're too busy. We think, oh, you're having trouble with name finding. We'll talk about that another time. I mean, I was guilty of all of this before I started working on this cognitive toolkit. So we know this happens, and it's really our job as PAs, we're leaders in our communities and in our clinics to make a difference here. And this is what we're going to continue to talk about. When we can engage patients and their care partners, that we can plan, we can reduce risks, and we can get them access to treatments earlier. And I want to highlight the term care partner because it's been new to me in the last couple years. We used to talk about caregivers, and now we're talking about care partners because so many of us are partners with our family members who are aging and going through this. And we're not always giving the care, but we're trying to work with them. And that's really what we need to do in dementia to reduce the stigma and increase the people in care. So now, what are some barriers? Why are we so bad at diagnosing it? Why are we missing this so often? And so there's patient-level barriers and there's provider-level barriers. So on the patient level, there's stigma, there's fear, and there's denial about cognitive decline. People are afraid of it, but let me know, like they are thinking about it, and the Prevagen commercials will tell you that that is true. So cultural and language differences can change how a person thinks about aging and cognition. And so that we may have to adapt how we operate in our day to try to do that. Some patients don't have insight into the changes that are starting to happen. They may not notice that they're repeating questions. They may not notice that they're forgetful, and it may come from outside of the individual. And some of our patients are still waiting for us to initiate that conversation. And this is where I think everyone in the room can really make a difference, because if patients are waiting for us and that's a barrier, that's on us. We can fix that. So on the provider level barrier, time. Of course, we never have enough time for what we want to do. And the trick is finding ways to make time and finding ways to carve that out and make the best use of the time that you do have. Then there's therapeutic nihilism. There's nothing to be done. It's futile. But as you see with Dr. Kaiser and everything we're talking about today, there are things we can do. We can work on modifiable risk factors. We can get a diagnosis. We can get people into treatment. So insufficient training or confidence. This was me. This was me before I started working on this. I can't tell you how many times I probably clicked cognitively intact during the annual wellness visit without actually studying it, without actually getting some data, because I know my patients, I see them socially, I see them out and about, I know their family members, and I think, yeah, they're cognitively intact, that's fine. But this is a real opportunity for us to not dismiss and not minimize. So lack of reimbursement for brain health services is absolutely a barrier. And the goal is that over time, we're going to do that. We do have some resources in the toolkit that can help, that can show you some codes and some different ways to build more time and more RVUs into your schedule. So overcoming these barriers, I kind of went ahead of myself, but on the patient side, stigma, fear, and denial. We do that by normalizing the conversation. Let's talk about your thinking. Let's talk about your memory. And we talk about your blood pressure every time you're here. We talk about your smoking every time you're here. Let's talk about brain health, because this will impact you and your family going forward. When there's cultural and language differences, if there's things that are affecting patients' beliefs, we want to address that. We want to use culturally sensitive language. And this is another opportunity to use open-ended questions. Can we talk about brain health today? We want to talk about memory and thinking and cognition. Is that okay? And let that be your entry into the conversation. When patients lack insight, it's great to ask them to reflect. We want them to, kind of gently nudge them. In my community, neighbors and friends will say, you need to talk to this person about these changes. We noticed some problems. And so then I can say, have you noticed noticed any changes? How do you feel like your thinking is? And so that opens the conversation. These are sensitive topics, and patients really need that open door to be able to confide in us because it's scary. And then when they expect us to initiate, we want to take the lead. So I want to make sure we talk about brain health. I want to talk about this every visit. I want to make time and make special visits just to do this. So when we're creating a safe environment for these brain health, and ideally we're doing this with all of our patients, but we're establishing rapport, we're demonstrating concern, and we're communicating with everyone as an individual. Nobody enters our offices just with what's on their chart. They're this bigger holistic person, and when our patients realize that we see them as a whole person and not as a disease process, they're willing to talk to us and willing to open up to us. So nonverbal communication, you want to face your patients directly, and this is really important in patients who have vision and hearing issues. So it's not just that we're looking at them and letting them know we're paying attention. We're making sure they can understand us and understand what we're saying. We want to make eye contact when that's appropriate, and we want to be open and not kind of closed off and hurried. I think standing is one of the worst things we can do in our practice because it makes our patients know that we're in a hurry. But if you sit and you talk to your patients, their impression will be that you have spent more time with them, even if you don't. And there's studies that actually show that. So when we're talking with our patients, this is not an I and a you situation. This is an us and a we. This is a partnership. We have to both do our part in order to maximize brain health. So we also want to ask questions. We want to be attentive and have empathy for what's going on because this is scary. Patients are worried about loss of independence. They're worried about loss of, their functioning. And so making sure patients understand what we're talking about so there's not misunderstandings when they leave the office. In the physical environment, we want to reduce distractions for us and our patients. My patients get on their phone in the middle of a visit, and I ask them to put it down. We want to make sure there's privacy, and we want to eliminate background noise, provide culturally and linguistically sensitive materials. In these conversations, I also like to, if the patient is willing, invite a care partner into this conversation. I think we get a much broader picture about what's going on, especially when we're talking about cognitive impairment, if we can include care partners actually in the visits and in the room. So when that's appropriate, I think it's great. So next we want to talk about practical strategies, and this is really where we can make a difference. And I want to impress upon you that the screening does not take a lot of time. There's follow-up and there's lots of things that happen. But if we're talking about identifying mild cognitive impairment and making a real difference, we can do this. And I challenge you to incorporate it. So it is important for patients to receive an early diagnosis. It validates the patient's concerns and it validates the family's concerns. When you're the child of an aging parent and you see what's happening and your adult in your life has not made that connection or gotten a diagnosis, it's validating to do that. Patients, when we see them and treat them in the mild cognitive stage, they are able to participate in their care planning. And this gives them a sense of control and it maintains their independence for as long as possible. And this is so valuable to their mental health and their brain health because they're open and they're talking about it. Patients are able to make lifestyle changes. We can make a difference. And so when we can control all of those risk factors, blood pressure, blood sugar, cholesterol, vitamin levels, we can slow the progression and we can make a difference. We want to improve their access to education and personalized support. We want to get them into treatment as appropriate because we want to initiate that in early stages. And they may also be available for clinical trials. So we want to increase the opportunities to make a difference in our patients' lives. So who should be evaluated? And to me, this is pretty much anyone. We've talked about it. We should be starting earlier and continuing through the diagnosis process. So anyone who self-reports, anyone whose spouse or family member or friend, or if in practice a colleague or someone else has concerns about a patient, then they should be evaluated. So we're going to ask about different cognitive, behavioral, and functional impairments during our annual wellness visits, but we can do that at any time. And as Dr. Kaiser said, we don't want to dismiss mild complaints. We want to make sure that we're paying attention to that, identifying it, and talking about ways to reduce those risk factors. We can use our electronic medical records to flag indicators and set reminders that we need to repeat some screenings and testing. So it is very important to screen adults for hearing and vision loss before doing a cognitive assessment because that will interfere with the results. I also make sure to kind of control my patients' anxiety because when we start to talk about brain health, they get a little nervous sometimes. And when they are very anxious about their MOCA or the upcoming test, it actually seems to affect their scores. And so we want to make sure that we normalize this and really reduce the stigma. So capture family concerns, and we're going to see the best ways to do that in some of our tools coming up. But family members and friends can often be the first, notification and the first alarm that something is changing, and we want to pay attention to that. So in the diagnostic workup for cognitive symptoms, we're going to get a patient and family history. We will get a perspective from the care partner. We're going to find out about their medical conditions, of course, lifestyle issues, smoking, alcohol, exercise, medication supplements, medications, including over-the-counter meds and supplements. This is where we can really see what patients are doing. Again, I can't say it enough. Have your patients bring all of their medicines with you. Have them bring that big bag. I had someone bring me a crate the other day. Bring it in so that you can look and see what they're doing. Not only can you find that your patient's been taking twice the amount of their statin and they forgot that they were supposed to be taking their ACE inhibitor, you can also see what medications are appropriate and not. So obviously, benzodiazepines, anticholinergics, antihistamines, opioids, and PPIs are all linked to memory issues. So we should be paying attention to that. Then our workup includes a bunch of assessments. I'll be honest, this is where the meat comes in. We're doing a neurologic exam to make sure we're not missing non-Alzheimer's pathologies and issues that can contribute to memory changes. A brief cognitive assessment with any of the tools listed there, some functional assessments, behavioral assessments. We can order some labs and then think about brain imaging. MRI is our preferred modality. Some of our patients can't have MRIs for one reason or another, and so you can do CAT scans. And then this is where you can get biomarker testing as well. So we're going to talk about the cognitive toolkit, and this is really the meat and potatoes of this early diagnosis. The AAPA and the PA Foundation partnered with the Cleveland Clinic to develop and launch this toolkit. There was the Davos Alzheimer's Collaborative provided the grant funding. This is the QR code. The registration is free, or it's free, but you do have to register through the AAPA. This is a phenomenal resource for getting started and for people who are not totally comfortable with this idea. This toolkit does not make you an expert, but it makes you very competent in making this work part of your daily practice. So there are self-paced learning modules, such as those listed there. There are screening tests. The 88, the Mini-Cog, and the MOCA are the ones that are mostly covered in the toolkit. There are resources with cognitive screening, templates for notes that you're going to include in your records, resources for clinicians, and printable resources for patients, and the ever important billing codes. So the workflow pathways, I kind of just wanted to talk through how I've done this because I have drunk the Kool-Aid of this testing. Patients, for example, they come in for an annual wellness visit. We do the whole screening, and we can use our support staff. They're asking the resource assessments. They're asking about falls. They're asking about meds. Our medical staff can administer the Mini-Cog, and then we can talk about that. And to me, the Mini-Cog is how I enter into the conversation. And then, if the Mini-Cog or even the patient's response to the Mini-Cog, if they score well, gives me an opportunity to talk about it. So that gives them, it creates a conversation. They can say, I'm really nervous about this, so-and-so worried about this. and it gives us time to talk about it. When we review the results, we should review them with our patients. We need to let them know what our findings are and let them know what our concerns are, the same way we worry when their blood pressure is 180 systolic. So we want to let them know. And this is the critical piece to me, is taking that additional time. It could be follow-up with an upskilled provider, and sometimes that's me just with another appointment. So sometimes that is what we do. Sometimes we refer them out. We can go to geriatrics, neurology, a brain health center. And sometimes we really need to get our pharmacy colleagues involved so we can work on deprescribing and changing medicines that might be inhibiting our patient's brain health. So really, this is doable. And I challenge you all to really make this a part of your practice on the annual wellness visits and any other time that patients have questions. These are some sample notes. So this is, samples, and you can create these into your own templates that you can put into your EHRs. It gives information, kind of ways to track it. These are some of the sample resources. So we talk about how important sleep is, the brain changes we're seeing, how important physical activity is. You can print these resources, you can give them to your patients, you can upload them into their charts, and it's really, really helpful. It's helpful for me because it helps me explain it to my patients in a way that I think they can understand. It's written at a great reading level. So these are the cognitive assessments that are included, the 88 and the Mini-Cog. Those are the ones that 88 really gets family member input, and Mini-Cog is done face-to-face with the patient. So billing and reimbursement, of course, these are some codes that are resources. It is helpful to schedule a separate visit. I noticed, I had extra time the other day, and my patient scored poorly on his Mini-Cog and his MoCA, and that conversation, it actually wore my patient out as much as it wore me out. So we had done a big annual wellness visit, and so it really was a reminder to me to set aside separate time. Let them come back, they can go home and think about it, they know what we're going to talk about, and they can bring a care partner with them. So I would encourage a separate visit whenever it's possible. And then now we're going to move on to Dr. Kilgore.
Thank you, Amy. I'm going to do this at a very high level. In my practice, I've screened about 1,500 patients using mental health and our mild cognitive decline tools. I don't mind sharing for those that are in the room, I've actually converted mine because 60% of my patients are Hispanic. So we have it in both English and Spanish so you can see what it looks like. So very quickly, we'll go through these. So the Mini-Cog screening tool takes about 3 minutes to administer. And again, it's available in many languages. We have ours combined. So you use a 3-word registration. So for everybody in the room, book, table, dog. Don't anybody write it down. Book, table, dog. All right? So you got the 3-word recognition. Then we go to the second step, which is to draw a clock. Put the 12, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. And then we want you to put 10 past 11. So that easy step, what we do is we do the word recall, 0, 1, 2, and 3, how many they remember, and then draw in the clock, that you get the clock correctly. Fairly easy to do. If it's greater than 3, it's a pass. If it's not, we go to the next steps. All right? The AD8, validated tool to get the care partner input, and is available in multiple languages. I use this all the time. So the structured questions come here. I usually give it to the patient while they're waiting for me, which is usually too long, and they answer the questions. I can easily look at this, evaluate it, and then in some cases, if there's 1 or 2 on here, there might be something else going on, but it gives me a good idea. These are screening tools, so it gives us an idea of what we need to do next. The third one is the Montreal Cognitive Assessment, the MoCA, and again, if anyone's not ever used this, you can look at it real quick. 1A, 2B, 3C, 4. Somebody that has mild cognitive decline could really struggle with this. Dementia, definitely. So you'll be surprised. So it's a good validating tool, and then you have them copy the cube. So again, another quick screening tool to give you some idea of what the problems are that the patient is having. Interpreting the results is one of the pitfalls and caveats. So there's situational factors that can lead to false positives. I know in my practice, I have a lot of patients that have mental health issues. So if there's emotional distress, fatigue, if they're acutely ill, if they've got sensory motor impairments such as hearing loss, vision, arthritis, or a mood disorder with depression, anxiety, it can impact the outcome. background factors, your education level, familiarity with the test format. If they've done it before, or we were talking year after year after year, we have to change things because they get to know the testing, and if they're testing on a good day. And then again, if they're low literacy, limited education, intellectual, developmental disabilities, cultural, language barriers, those are going to be problems you're going to have to decide if these tests are appropriate for that particular patient. So the key thing, and I preach this all the time to my students and other people I work with, it is a team-based approach in how we approach patients and then how patients get treated. So your primary care providers, your PAs, NPs, your physicians, they have to initiate this screening. The pharmacists, polypharmacy is a big problem, and that's something I always look at very quickly. What drugs are they on if they're having issues? Are they taking something, they're taking Benadryl 6 times a day or something, and then they're kind of dopey, and you say, what's going on? You check their medicines, you find out they're doing something, or the combinations of medicines. Behavioral health specialists, they can do the mood and anxiety disorders. The neuropsychologists also can do the in-depth cognitive testing. And a case management social worker can help, especially with the families when they're planning for how to deal with somebody that's having a cognitive decline. And of course, the family care partners. Many of us in this room probably have been touched by people that have dementia in your families, and it is a tremendous effort to take care of those people moving forward. So how do you act on this? If the evaluation looks okay, you want to discuss all the things that we've been talking about. How do you stay healthy? What do you eat? Do you exercise? Do you sleep well, etc.? If there are contributing factors found, such as alcohol or wearing hearing aids, they got sleep apnea, they have depression, or they're polypharmacy and we need to take some of the drugs away, those things need to be addressed. And if it appears that patient may have MCI or dementia, you need to acknowledge that issue. You need to encourage the patient that you'll work with them to address issues. And then also for me, I always refer to my specialists that can help me in dealing with our patients. The important thing is just don't diagnose and dismiss the patient. Come up with the plan to make the next steps. That's critical. So have a family member present is important, especially if the family member comes in and says they lost their car in the parking lot again. They're not just losing their keys, they lost their phone. They don't even know, where they went yesterday. There's all kind of things that start adding up. Family members will say something's off, all right? Get permission from them to say, can we talk about this? And then acknowledge fear and share some hope and optimism. Just don't paint a bleak picture. Make it clear that you'll provide ongoing support and tell the patient that this is the first in a series of ongoing visits so you can continue to evaluate them. So indications for referral, inconclusive diagnosis, you just really can't tell by looking at your screening test what's going on. Atypical presentations with patients coming in, behavioral psychiatric symptoms, younger age, age less than 65, we try to start screening around 50 in our practice. Second opinion is requested, or they want a specialist to see the family member, or there's a family dispute. Nothing's wrong with mom. Mom's okay, but mom left the gas on at the house or left the water running, and the family member said, you just got this argument going on. Sometimes it's best to involve somebody else in that situation. And then, as we were just mentioning earlier, the biomarker testing that's available. The families may request that, or the patient may request it to find out if there's a definitive diagnosis. So here's a critical thing. The non-pharmacological treatments that we were talking about, regular physical exercise, heart and brain healthy nutrition, keeping your brain active, being social, memory training. I saw a couple of questions come across a few minutes ago about that, isolation, etc. We'll talk about that. And then looking at the cholinesterase inhibitors, and then the NMDA receptor antagonist. And for my military friends who are here tonight, that's November Mike Delta Alpha. And then again, the real interesting things is the monoclonal antibodies, which are specific and have an impact on amyloid. Lots of options available and new options coming down the road. All right, we got through this. So we're going to do the workshop. So each table should have the cases. So Group 1, 2, and 3 each have a different case. Patient number 1. So I asked Travis to go around and just ask a few questions of the tables. What modifiable risk factors for dementia are present in Ruth's medical history? And Ruth is a 78-year-old woman who presents for a new patient visit with her husband.
So some modifiable factors we're looking at, obviously she has the depression and anxiety, and then we're really looking at her polypharmacy, so using the diphenhydramine at night for her sleep, And the big change from sertraline to clonazepam seemed like a pretty big issue for those modifiable factors from the psychiatrist. In addition, maybe some social isolation. She is retired. We can't expand on that too much, but she's probably having some social isolation. And with her history of osteoarthritis, we are worried about she's probably not getting the physical activity that could help her.
So we were talking with some of the group 2 folks about what brain health risk factors Marisol has. And Marisol is our 72-year-old widow. Spanish is her first language. She's retired. She's on some anticholinergic medicines. She has some hearing loss. Her hypertension is managed, so we saw that as a positive. Her overactive bladder is managed, but we had a concern about the medication it was managed with, but had to weigh those risks and benefits and talked about shared decision making. She's concerned about vision and cataracts, so we're looking at vision changes, and then the changes that her daughter has noticed as far as her cognitive changes. We talked about, would we perform a cognitive assessment? And we were thinking we would love to have the opportunity to at least do a Mini-Cog and then schedule a follow-up visit.
Great. Thank you, Amy.
So we had a 52-year-old gentleman, yes, who was being seen for a follow-up visit to review recent lab work. And the question was, did this gentleman have modifiable brain health risk factors within his history? And the consensus was, oh my goodness, he had a lot. He had hypertension, type 2 diabetes, he was obese, he was likely physically inactive, but we needed to get more information about that. And so that was a real concern. And then the question was, did his lab work show that he had, now that he has type 2 diabetes, the lab work showed that he now has type 2 diabetes, so what treatment plan would we like to discuss with him? And so people were thankfully talking about lifestyle interventions, reinforcing efforts to change his diet and assess and address physical inactivity. There was discussion of medications, potentially starting metformin, even some discussions of would GLP-1s play a role at some point for this gentleman, monitoring his blood pressure, his hemoglobin A1C, his lipids, considering referral for diabetes education. Lots to do, and discussing, when we're thinking about potential complications, brain health within that. And then the question was, can we tie this brain health and heart health together to help motivate this gentleman? And then, there was a lot going on at this visit. So should we bring up brain health explicitly during the visit, or should we wait for future opportunity? And what kind of influenced the decision was really wonderful is people said, you know what, we can normalize brain health. So let's talk about it now. Obviously, we're going to have them come back. We've got more to do. But, this is all part of our healthy aging. So it's not something that needs to be put off. We're going to have you come back and spend more time thinking about it. But for now, we've got to think about brain health. This is a big part of the picture. And then a lot of great opportunities to monitor and address this over time. So we're not going to just let Marcus go off into the night. We're going to stay close, and we're going to be monitoring all of these factors. Really good case and great thinking over there.
Great. Thank you, Dr. Kaiser.
At ours, from Lilly Hannah talked about how important it is to use the terminology for a health, where we get into, our patients thinking, oh, you want to talk about memory? Well, my memory's fine. I don't want to talk about memory. I want to talk about cognitive decline. The eaginess kind of brain health might open the door to the conversation so that we can realize adding conversations.
Great.
We talked about what concerns or priorities would you want to discuss with Ruth and her husband with the next visits. We talked about ADLs. We talked about support visits. We talked about were there any concerns regarding driving, day program, if she had gotten lost in the past, meet with the patient with and without her husband at the time. Is there any social isolation? We talked to possibly some other family members, maybe some substance use if there's any alcohol. She's drinking some alcohol in excess, and then just accuracies of information, social activities.
Right. For our patient in group 2, one thing that came up in our discussion was her grief concerns addressed? She lost her husband recently, highly dependent on it. So did they address her grief concern? Maybe we'll get her into some programming socially for addressing her grief. And also addressing the transportation concerns. If she's only relying on her daughter, maybe there's a community outreach for her to be able to make appointments and just have some more socialization.
Absolutely. Those are really great points. So one question that was asked, I'll let y'all think about it, but we'll ask Dr. Kaiser who wants to answer first or not. Do probiotics make a difference?
You know, the connection between the microbiome and brain health is a fascinating area. A lot of great research on that. But I don't know if there's anything that it's very difficult to study. So I would say it's an area of ongoing research, and guidelines around probiotics should be connected with more general kind of guidelines around probiotics. So they definitely have a role. But in terms of, again, no question, there are critical connections between the gut, microbiome, brain health axis, and people. We mentioned BrightFocus Foundation. I'm on the board of BrightFocus Foundation, and we fund research in Alzheimer's disease, macular degeneration, glaucoma. Just released a round of grants for about $13 million worth. And it's fascinating to hear the world's leading scientists really focusing in on that area. So awesome question, but sadly, I think a lot more questions still than answers in terms of how to guide our patients.
I think we can always improve our diets. No
Yeah.
doubt about it.
Yeah.
So I'm going to punt that Amy since I'm getting asked the question. So that's the cool part of doing this. So the next question has to do, when do you actually start screening patients? There could be other factors, but we'll let Amy. So what trips you to say, this is the age I want to start screening my patients?
For me, it's the minimum of 65 because I incorporate it into all the Medicare wellness visits. But there's opportunities anytime people say that they have any questions. When we're in the visit and they have trouble word finding, that's an opportunity for us to talk about that and build in some screening. So I keep the MOCA handy. I keep it up on the electronic medical record, and I keep it right in my desk drawer when I'm seeing patients. And so I can pull that out, and that's 2 minutes. So anytime someone has a concern, anytime someone mentions their supplement list and they're taking a supplement and they say that it's for their brain, that's an opportunity to start that conversation early. So 50s is easy to do that for sure.
That's great. All right, so some take-home messages from tonight. Brain health is a lifelong priority. We've already been talking about the cradle to the grave. We treat every day throughout your life. Modifiable risk factors offer real opportunities to reduce dementia risk. Perform cognitive behavioral function screening on all adults with suspected cognitive decline, and get family care partner input whenever it's possible. Context is important when interpreting. We went through that list of things you need to take into consideration, such as education, culture, etc. And then employ principles of shared decision-making when you are engaging your patients and care partners in informed discussions about assessment, diagnosis, and expected clinical course. There's not a doubt when we have patients that have a problem, we end up with long discussions with the family, how to plan, how to prepare, what medications, etc. Do we need to put somebody in a home? Well, no, that's not what we start out with. So you need to have those discussions with people. So again, we have a lot of patient and healthcare provider resources, publications, free publications about Alzheimer's disease, and then there's also provider resources that are available. So y'all want some more questions? My state is currently illegal, and the state can't decide who to let grow the marijuana and make the gummies and make the medicine, so we're all messed up in my state. But your experiences?
I mean, I wish there were a simple answer. We could do a whole nother session on that. And there's a lot of mixed literature, and some of the studies indicate really that cannabis will impact your short-term memory primarily while you're under the influence, but may actually be there's a whole literature around the neuroprotective effects of it. So, not something, obviously you need to be cognizant of potential med interactions, and it's an evolving literature, and it's been so hard to study robustly. But if you look at There was a real robust literature out of Israel where there was actually great promise, particularly in geriatric patients. With cannabis, we're a lot more concerned in the younger population, obviously. And then in terms of the effective management of behavioral and psychotic symptoms of dementia, where we don't have a lot of really good options, there's been some interesting work. So hard to say, and something to stay tuned and to be aware of. Sorry, there's not a more clear, definitive answer. And I'm sure you can find people who say, absolutely not. And then you'll find people who say, oh, for everybody. But I think we really don't fully know. But the neuroprotective aspects of the cannabinoids is pretty compelling stuff.
I was going to say a lot of opinions, but not a lot of research.
Yeah.
So is there another question that you saw?
Oh, there were so
There are
many
so many
here.
good ones.
This was a quick one. Do you have to be certified to perform a MOCA? Well, what's wonderful about the MOCA is it's not copyright protected. So you can just go onto their website and you can do a training. They do like you to do the training, and then you can do a MOCA. And it's really good to know how to do it properly. And then I just love doing the MOCA. I mean, you can delegate it to somebody else in MA or something. I love to do it myself with the patients because it takes you through all these different domains, and you get to see kind of their thought process literally as they go through these executive challenges and challenges of attention. And you can download it in multiple different languages and different versions, because obviously you don't want to give I don't know if you were going to test them on the 3 words already, but if you give them the same 5 words every time, that's no good. So they have different versions with different pictures and different words and slightly different shapes. And so different languages, different versions. And then it is adjusted for education level, which is really important as well. And the most sensitive, among the most sensitive and specific for MCI. Mini-Cog is fantastic, but you're going to miss a lot of MCI because it's more sensitive for dementia. So with the more subtle changes, so look, people have their favorites and they love the slums, and that's great. You should just use a validated. I'm not here to sell the MOCA. You use a validated instrument. But I just gave the reasons that I love the MOCA so that you can think about that in terms of the instruments you choose to use, that what they're good at, where their gaps are, etc.
Okay, great. Now, what were the 3 words I said? See, you guys are good.
There's a couple questions that, if we have time to, when do you start medications versus referring for further testing, or when you think that a patient might need a medication and you identify dementia and you refer to neuropsych and there's a 6-month wait, what do you do? Can you start medicine during that time or not?
Yeah, I mean, we could all weigh in here, but obviously we didn't get so much into the available medications in this session because we're really talking more generally about brain health, right? So you have your symptomatic therapies, which are the cholinesterase inhibitors and the NMDA receptor antagonists, so like memantine. So you can use those. You just need to help patients understand that the evidence is that they're symptomatic therapies. So the way I explain it to patients often is it's like, look, if you have a cough, we may be able to give you a cough syrup that may lessen some of those cough symptoms, but it's not treating the underlying disease, whether it's a bacterial pneumonia or a viral URI. You're not actually treating the underlying process. It's just a symptomatic. But people do benefit from that. So I think that it's good to think about using those at the early, and the cholinesterase inhibitors are indicated for mild dementia and Alzheimer's disease, but reasonable to use them even off-label in MCI. The important thing is that don't just throw the med at it and then just be done. You've really got to do the full assessment. You've got to be addressing all the others. I can't tell you how many patients I see who somebody just started a cholinesterase inhibitor and said, all right, see you later, and that was it. Just, okay, you're having memory problems, try this. No, you still need to do this thorough assessment and have this multimodal way of addressing their overall brain health. And then in terms of actual disease-modifying therapies, We now have these 2 new FDA-approved drugs, right, that target amyloid. And those, as we indicated in the presentation, are for folks who have an established diagnosis of MCI or early dementia, and you've confirmed that they have the Alzheimer's disease pathology. Clearly, it wouldn't make sense to give a drug that clears amyloid to somebody who doesn't have amyloid, right? So you have to confirm sort of the stage of where they are cognitively and functionally and the pathology they do or do not have.
I want to remind you that AAPA does have available a toolkit, so you can download that and get access and do the training and even get more additional resources. All right, thank you guys for coming tonight. We really appreciate it.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, BrightFocus Foundation. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/NDZ860.